thinking is just this idea that is just this idea that, even if you don't identify as particularly religious or spiritual, you're still finding meaning in other ways. And what research has shown is that AYs specifically identify more and more as nuns. Has anybody heard that term before? NONES. Yeah, so Pew Research is a pretty big organization that does like religious landscape studies in the United States. And over the past 10 to 20 years, this age range, AYAs, is more and more identifying as nuns, which means that they don't want to associate with religion and they don't want to identify with spirituality. So they kind of say, I'm a nun, not N-U-N. But obviously, they're still finding meaning in something. And so by kind of utilizing all three of these things, we can hope to understand what people are identifying with and give a space for everybody to find a place in this study in terms of talking about their beliefs. And so this is a very simple in terms of it's a non-intervention style study. It's going to be a few assessments, one that I'll be giving to assess religious coping, one that will be assessing spiritual coping, and then some measures to look at health-related quality of life and resilience. I'm also going to be including a short qualitative component at the end, because when we're talking about issues of religion or spirituality, it can be hard to kind of quantify those things. So I wanted to provide a space for patients to be able to be a little bit more free in their responses. And so the mission of this study is really just to see what are the associations of these patients' beliefs with their psychosocial adjustment. Are there associations with health-related quality of life or resilience? And what does that look like? It's also important to note that religious beliefs or spiritual beliefs aren't always necessarily positive. There is such a thing as negative religious coping or never negative spiritual coping. Is anybody familiar with that distinction? Yeah, so again, this is where the research in older adults is a lot more extensive. So studies have found that religious, negative religious coping can actually significantly impact decisions made at the end of life in a negative way. So, for instance, a patient might feel that they are being punished by their cancer diagnosis for a sin that was committed years back. So they might choose to engage in a more aggressive form of treatment as like a source of punishment. Or they might say, I need to continue to engage in treatment because if I don't, that means I'm giving up on God. So these are really important things to highlight because unless we're assessing for that, we don't really know what could be fueling these decisions for patients. And again, those are extreme cases, right? Towards the end of life, et cetera, in older populations. But I think especially in AYAs, this is something that warrants attention. And so my study aims, I'm going to breeze through those, but basically just wanting to see what are some patterns that I can see, positive religious coping and positive spiritual coping. And I want to figure out, how are these associated with health-related quality of life and resilience? Again, not assuming any type of causation to be garnered from this, but just to see what are these relationships like. This will at least provide some groundwork going forward. And then again, for that qualitative component, I really just wanted to go to the source, ask the patients, is this even important to you guys? Is this worth asking about? Were there times along your cancer journey that it was the most meaningful or helpful? Were there any barriers to talking about your beliefs? So I really wanted these participants to feel like they're kind of paying it forward. They're like informing future interventions. And so the goal is to get about 115 patients. Eligibility is that they're currently between the ages of 18 to 29, but they can have been diagnosed between the ages of 15 and 29. The reason I did that little switch there is because when it's younger kiddos, it involves assent processes, et cetera, and I'm hoping to use online recruitment just to increase feasibility. So again, recruitment will occur predominantly online. People will scan a QR code. It will be taken to RedCap. They'll fill out a few surveys, and then there will be a participant compensation at the end in the form of a $20 Amazon gift card. And it's anticipated that participation should take between 30 to 45 minutes. I definitely didn't want to make this a burdensome experience for the patients. So it should be fairly quick. And of course, I'm hoping to utilize you wonderful people and other organizations that are really committed to helping AYA cancer patients. And honestly, AYA is like online stuff anyways. So I feel like the days of in-person recruitment are not as feasible all the time. And I think this is a good way to reach out to them. This is just more about the measures that I'll be using. I know we're crunched for time, but I'm also happy to send out information about the measures if anybody has any questions. But yeah, I realize I'm like just going all over the place, but I think it's really exciting in that I don't think anything like this has been done before. A lot of religious coping or spiritual coping assessment has occurred in, like I said, older patients or caregivers of younger kiddos with cancer. And so this will give us a nice uh, point of reference for seeing what are AYs feeling these days? What are they believing in? What drive gives them meaning? And is this something that we can foster and promote, not only at the time of diagnosis, but throughout their survivorship?
I love this.
Yeah. So
Yeah,
I recognize I just sped through that, but I didn't want to keep you guys longer than I needed to. So I will stop sharing. Anybody have any questions?
I don't see any, but if anybody thinks of any or wants to be connected to Rebecca too, please reach out. And Rebecca, anything that you're willing to share of your presentation, please
Oh
let
yeah,
me know and I'll add that to the circle.
I can send all the slides. I
Cool.
can send all the slides. Yeah,
Great, because I think there's a lot of information in there that people might be interested in that's new or
absolutely.
haven't seen in a while or needs to think
Yeah,
about more. So we really appreciate you coming and sharing this and good luck with your work. And please let us know when it's open so that we can share that
absolutely.
wide.
Absolutely. Thank you all so much for letting me share that. I appreciate it.
So Bryn,
Okay,
oops,
let me get my screen up. Can you all see that okay?
yes.
Awesome.
And Andrea or Andrea, we have been talking and I've never asked if it is an and or an on. So, and it's also, are you an Andrea or an Andrea?
I'm from Chicago, so it's Andrea.
Thanks. Go ahead, ladies.
Awesome. Well, we are here today to chat about our EDW dashboard that has been a long time coming. So that our program spans Northwestern and Lurie Children's. However, this dashboard is just functioning in the adult setting right now because we have different systems. So I just want to set the tone right there. So, as sort of a reminder, this is our team, and Andrea is our newest addition to our team. If you all haven't met her yet, she's wonderful. She started in June, like 1 month before both Jenna and I were out on leave. So she has learned from the fire hose and has handled it with incredible amounts of grace and just is far exceeding all of our expectations. So she is phenomenal, and I can't wait for you all to get to know her as well. So with the addition of Andrea, we have sort of reworked our workflow, and I'm going to show you our updated workflow because how we use the EDW is very much a part of our updated workflow. So I won't go through all this super in depth, but just quick highlight. As far as how AYs are entering our program, they can enter from direct provider referral. They can always self-refer, or our kind of other proactive measure of identifying people is now utilizing the EDW dashboard. And then Andrea reaches out to people via MyChart and sends them the NASB screening tool. And then she has an initial encounter with them to kind of go through patient assessment and then triages to other people as appropriate. And so one of those referrals that she sends is now to Jennifer Carrera, who does kind of a more in-depth psychosocial support with them. And then she continues to follow them over time. So back to the EDW, this has been an extremely long process. And initially with the data team, there was just a lot of discussions of tell me exactly what your program does and how you're functioning and what's not working, what is working, so that they could sort of help us to identify what our data needs really were and what needed to be tracked in sort of an ongoing or more regular fashion versus periodic data pulls. So from the time our program started, we had an EDW report that we could pull, but it required insane amounts of data cleaning and a lot of time. And so that was only really feasible to do a couple times a year because it was so laborious. And so there may still be times when we choose to extract data from the EDW like that and do more of a deeper dive, but now we can see a lot at a higher level every day, and it's regularly updated. So that's been really helpful. The other piece that took a lot of time was to decide what are our qualifying metrics, which just basically means what is going to pull people into this dashboard. And this required a lot of conversations and back and forth. So the first one, all three of these criteria have to be met for someone to be pulled into our data dashboard. They have to have a qualifying cancer diagnosis. So we had to literally comb through ICD codes and create, here are all the cancer diagnoses that we consider eligible, that we want pulled in. The next is they have to have a visit in a qualifying department. So we were looking through all the departments in the cancer center and pulling in the departments that people would be seen in that we care about. And then the last one is the type of encounter. So we care about office visits, we care about telephone, we care about my chart. So all of those different things. And then there are some that we don't care about. The next piece was deciphering how we were going to distinguish new versus return patients. And at least in our Epic system, there is no discrete variable that says here is the patient's date of diagnosis. And so it's very hard to say, well, who is a new patient? What does that mean? And there's not really a definition that's accepted across the cancer center. So we had to sort of come up with our own definition. And this is far from perfect, but it is working. Okay, so we call somebody new if their first visit in the cancer center has happened within the last year. And then their return if their first visit was more than a year ago. So obviously that's an ever-changing target every day. And so that we had to build that into the dashboard as well. So after we sort of figure all these things out, then it was my lovely job to do all the testing and data validation. So pouring through data sets, comparing in Epic, is this accurate? Is this not? What do we need to change about the code to make sure we're getting as accurate as possible? At the end of the day, there's always going to be things about our dashboard that are not perfect, but we just sort of had to get it to a place where it was doing a good enough job, because anything that it does now is better than how it was happening before. So this was a lot. I mean, a couple years. So just to set the stage. So patience and a whole lot of persistence was very necessary. And here we are. The dashboard is now live. So this is just what it looks like when we get in. I put this bar across the bottom because these are all the different tabs that exist within our dashboard. So there's a lot that I had to kind of block out, so I didn't show any patient data, but I think you can still get a sense. So I'll just quickly walk you through each of these tabs, and then I'll also let Andrea chat a little bit about how she's using it in real time. So the first page, this may seem silly, but this is just a definitions page because we wanted to be sure that anyone who logs into our dashboard is able to look at it and understand the data and have all these definitions at their fingertips. So that's here. The next page is our demographics page. And so we have everything from the new versus return, and then all this other demographic information. Over on the right-hand side, you'll see we have a series of filters. These filters exist on each tab of the dashboard. So you can filter it by a certain date. You can filter it by folks that have seen some of our AYA staff. You can filter by age, new, return, and then all the locations. So Northwestern is a large system of hospitals. And so we have been functioning just at our downtown location, but we're actively expanding into other hospitals that are part of the Northwestern system. And so this is a really important filter for us right now. The next page allows us to see some information on clinical trial enrollment, basically to just be able to say how many of our AYs have ever been enrolled on a clinical trial. And then in the middle, this actually populates patient names and MRNs. And if it's an orange square, that means they are enrolled in at least one study. And if it's blue, that means they're not enrolled in any studies. So that can be interesting to see. This tab is an important tab, but this isn't one that we need to regularly monitor. This we call clinical encounter metrics. Another way of saying that is like productivity. So here I can see, and again, I can use any of the filters. I can see how many new versus return patients each of our staff members have seen in a given amount of time. I can see what types of visits they're having, if they're meeting people in the office, over telephone, and it just kind of can summarize those encounters. So again, back to the patient outreach part, I kind of went through this already, but before we had this dashboard, we had several lists that were provided by different clinics, or Jennifer Carrera was literally just combing through schedules to find people. And it was a very time-consuming process to be identifying these patients. And so we are always trying to think outside the box, how can we streamline this and make this much more easy for our staff to identify who we should be reaching out to? So this tab is really the bread and butter of the dashboard, in my opinion. And this is what Andrea is using. So I'll give you a brief overview of this, and then I'll let Andrea talk for just a minute about kind of how it's working for her, how she's utilizing it. So now the filters are up at the top. The key for this tab is, and I probably should have enlarged just a little bit, but are these different colored boxes and different ways that we group patients. So if someone has a red square, those are the folks that we want to be seen ASAP. These are a newly diagnosed AYA. So again, their first visit within the last year, and they have not yet had an encounter with any of our AYA staff. So those are the ones that Andrea is prioritizing. If it's a green box, that means they're a new patient and they have seen our AYA staff. If it's a blue box, it means they're a return patient and they've seen our AYA staff. And this is all within the last year. And then if it's a yellow box, this is a return patient that has not seen our staff. So our program priority is to see all newly diagnosed patients. So right now we've just told Andrea, focus on the red boxes. Let's turn all of those as much as we can to green. And then as time and bandwidth allows, you can see some of the yellow box patients essentially. So here she can filter by locations and everything like that. So she's able to then really easily see who needs to be seen. And let me just tell you, we have very few red boxes because Andrea is just that amazing. So I will share a little bit more once Andrea's done chatting about just what's to come, because this is not a finished product to us. There's still a lot we want to do with the dashboard. So I'll share a few things that may be coming in the future, but I will stop talking here and let Andrea chat about how it's working for her.
Hello. I will absolutely, I'm more than happy to have any questions you guys have too, because I can understand this can be kind of confusing. So on the specific, this is essentially how I live my life. So in the specific region, right now we're just doing the central region. Northwestern is gigantic. So the AYA program is exclusive right now to the central region, which essentially means Chicago, the city of Chicago. That does expand out. We have clinics, oncology clinics and hospitals, full hospitals all across the Illinois system. So north, south, west, northwest. So January 1st, we will be going live or launching into the Western region, which is 3 additional hospitals, 3 additional cancer centers, and a proton center, as well as our children's hospital. So more to come on that. So when I do, I live out of this patient outreach tab. And so what I kind of do is on the left, I want to see the null patients. So my goal is to reach out to patients who have never seen myself or Jenna. So Jenna is my right-hand man. I love her dearly. She is just the best ever. And she was doing outreach essentially from just lists, like Bryn had mentioned. So now, if her name is on a chart and she's done an encounter on that patient, we utilize Epic. They will not populate for me. So I kind of then am able to pull this data. And as of yesterday, because I was working a little bit on this, you can smack my hand a little bit, Betty, during the Gab Fest last night, because I want to be able to get, I try to do some of my outreach too, and I'm just multitasking as we always do. So as of last night, there should not be, now this specific dashboard that she has pulled up, does include all regions, but as of last night, there's no red dots for the central region, meaning that in our report, which does not pull in all patients, it does not pull in inpatients, it will not pull in a stage 4 who was diagnosed prior to 365 days ago. It will not pull in, I'm trying to think of other outliers there. So, I mean, there are still some things we're trying to monkey with. But what we're getting at is in the data that we're able to pull in this new dashboard, I've been able to then do outreach to every new diagnosed AYA 15 to 39 diagnosed at Northwestern Medicine in the central region that has had his outpatient appointment in 2024, which is very exciting. Then in my downtime, I'm able to what I'm also doing is looking at these low priorities. So then I'm trying to find my stage 4s is essentially what I'm doing. I'm trying to, yesterday alone, I think I found 5 and I was like, oh my gosh. And I was actually really excited. I know that's only 5 patients, but it means something to those 5 that were diagnosed. Maybe they were stage 2 initially and they could have been diagnosed in 18, 20, 22, but now they're a stage 4. So they will populate not as a new patient, but as a follow-up. So that's like the more cumbersome type of things. Excellent question, Michelle. I will get to that in just a second. So initial outreach that I do is once I have a new patient, if this is not a referral directly from the inpatient or outpatient team, if it's not a self-referral, if it is not via the census that I look at, then I initially just send them a MyChart message. Bryn, guru of all things tech, has made this beautiful template that is purple for Northwestern, blue for Children's Hospital Lurie, and it essentially says, this is who I am, this is my role. It's got the QR codes because that's what we've been told the AOAs like to utilize. One for our resource packet, one to find out our information on groups and information on how to contact to get involved with groups. And the third one, I am drawing a total blank, is for our website as well as
Newsletter.
Newsletter, thank you. And then you can register for our newsletter. Sorry, multiple brain issues. So they will initially get that. At the bottom is my phone number, and they can always respond via MyChart. So then because it's in the medical record, I'm able to see who acknowledges it, who even reads it, right? So this first month back in August, I was actually going into every chart after, like, is this person even reading it? Because if people aren't reading it, why are we going to continue doing this? And we had a huge, I don't know the numbers. I want to say greater than 80% people were at least reading the messages. They weren't necessarily engaging, but they were at least reading them. So then based off that, and if they respond to me in any fashion, then that's an immediate, I call within, a timely fashion, usually in less than 24 hours. And I'm able to, and if they fill out the NASB that's also within there, then I can really hone in on what I can do to help them. And that's only what I can do to help them today, because I essentially tell them I'm here forever. I'm not going anywhere. So then I can help you with whatever you need at different stages. And some people, were diagnosed a month ago. Some people were diagnosed 6 months ago because this is all new to us. So I'm still doing outreach to people who were diagnosed in January. But now that I've caught up a little bit, there shouldn't be anyone that's newly diagnosed that I'm missing unless it's an inpatient only, if that makes sense. So that's essentially when I create a telephone encounter. And so I document that I sent them the MyChart message, and then I'm able to call them. I usually leave them a voicemail, have them call me back. Some people prefer to talk to me via that. Some people prefer to talk to me purely based off of my chart, which is also a thing that the AYAs love to do. They just love to send my charts back and forth, back and forth. So I'm able to do that as well. I don't want to just keep talking, but I would love
Yeah,
to.
just two quick questions. I'm sorry that I didn't define EDW before Betty put the abbreviation in the chat, but just to clarify, the EDW is a web tool. I can't speak to all the tech of it, hosted through like Tableau or something, if that means anything to any of you. But it's pulling data from Epic. And so anything that is a discrete data field in Epic can be pulled into the EDW. And then we define encounters as a variety of things, Michelle. So it could be a telephone encounter, it could be a my chart, could be an office visit. All those are counted as an encounter for the EDW purposes. So a couple of things to come, and then I will open up for questions for either myself or Andrea, is we're working to generate a smart form, or sometimes they're called flow sheets, to be able to have some more discrete data variables. So we want to pull in like some of the fields from the NASB into that, so that we can track some of these things over time. We also want to better integrate fertility and survivorship data eventually. And then a whole other behemoth is to then try our best to replicate this in the pediatric setting. Our pediatric hospital does not utilize the EDW, so we have to be a little creative in how we do it. But I think there have been a lot of lessons learned by developing this that hopefully we can develop a similar system for the pediatric setting. So with that, I will leave it open for questions, and feel free to just unmute yourself too. I see a few questions have popped up. So you can contact all AY eligible regardless of a consult placed. Yes, we can. Initially in our program, we were a little bit more cautious about that, but now providers just know that we will do this. They can always place referrals as well, but we will be proactively contacting AYs as well. Is your dashboard part of Epic? Yeah, it's an independent database that pulls from Epic. So you don't access it from Epic. Okay, I think that was the only questions in the chat. Any other questions?
Well, this is Michelle from Iowa. I think this is absolutely lovely, and I'm in the process working with our data analysis teams on our dashboards. But like, is there a way, can I ever show them like these kind of screenshots or something of what you guys are doing?
Yeah, absolutely. I'm happy to share these slides, or if there's other things that would be helpful, I'm very happy to share whatever we can.
Okay. And our team is like, they always tell me they can't pull clinical trial information if a patient is part of a clinical trial. And there just has to be a way in Epic, right? There just has to be.
I mean,
What I have learned a lot though, is it's really about documentation. If the doctors don't put in a diagnosis,
Oh, yeah.
the EDW is not going to pull it.
Right.
You know, I can't tell you how many patients may be listed as like a DCIS or something. And in actuality, they're a stage 2, and that may have it in the path, but because the doctor never changed the diagnosis, it's not going to pull stuff in to the EDW. So there will be those outliers. So that is something that we're still obviously figuring out. So it just means that there are going to be people we're unable to reach, which is so disappointing to me. However, I am one person, so I don't, you know, I just kind of say it mattered to this one. That's how I kind of get through it, is like, it matters to this one. It matters to this one. I'm going to do the best that I can. My team is phenomenal. And it's very cumbersome, but it's very great to be able to pull that information in, and we're able to see the turnaround. And we do include our NASB in that in our initial MyChart message. And I think since we started, we've only had 60 people complete the NASB, but still that's 60 people. And all of those people who complete the NASB, I'm going to be completely transparent. I've probably talked to each one of those people over an hour on the phone, because I am going into full depth of our program, full depth of things like that. That doesn't mean that I haven't engaged with more people. I've engaged with many, many more, but And so that's about a 7% turnaround on who completes the NASB. So we have more to come to discuss if we're going to continue things like that.
And did your dashboard, I'm sorry, show referrals that you guys made?
That will be coming as part of the smart form. So not yet, but that's in development. Yeah. I saw a question about is it expensive? We did not have to pay anything out of pocket for this. However, I will say there was a lot of advocating for this to be a priority and gaining buy-in from administrators because of how they kind of schedule work into their sprints, they call them. And so it did require a lot of advocating for this to be a priority for the Cancer Center. Yeah. Kara, did you have a question?
Do we lose her?
I
Kara.
don't know what happened there.
Kara, are you talking on mute?
Yeah, I'm talking on mute. My goodness, I'm sorry. Hi, everyone. A few questions. You guys have done an amazing job just trying to get a dashboard set up. I always say like aim for a B minus and then build from there. I just did some major updates to ours, and it's just I already thought of other things that I wanted to do. So kudos to you guys. I really love your approach with my chart, and so kudos there. I think that that also shows when you go to expand to other areas that it shows that like you can expand by and you are getting a response. And so I have a lot of hesitation with utilizing my chart, and so do some of our docs, but I think the more that people try to do it and show at least something from it is great. So thank you for doing that. My one question I had is with your guys's like inpatients, do they end up hitting your dashboard after they finish like an encounter, or are they always not going to show up?
So if they have an encounter in any of our qualifying departments, which is basically any outpatient clinic, then yes, they do get pulled in. But that data is just kept in a totally different system in our hospital, which is just sort of mind-blowing and strange. So we would like to figure that out. The other system that is very separate is proton, or in all of radiation actually is very separate. But if they ever have an encounter in one of our qualifying outpatient departments, then they would get pulled in.
Okay, that makes sense. And then one last question with your clinical trials. I think I like spaced out a little bit. Is that pulled from, where is that pulled from? Ours, I had to create a separate dashboard through Tableau and it links to Encore. But does yours link to Epic?
Ours is through Epic. Going through Encore is probably more accurate. However, this was like what we needed right now was just a really
Sure,
high level
absolutely.
baseline.
Absolutely.
And so that was like good enough for now. Yeah.
Okay. I just connected our smart form, like I said, and so if you need any advice there, let me know. It's been a game changer. So
Yeah,
kudos
would
to
love
you.
to hear what you're doing there. Are you working with the data team from the Cancer Center or the hospital side? This is through the Cancer Center. I don't know if that's a helpful answer, Shu, but yes.
And then Michelle would love to see your MyChart messages, and Andrea just took care of that. Excellent. So if anybody else has any questions of these two, please reach out to them. If you don't know how to, reach out to me, and I will upload this recording and upload any slides either of these presentations are willing to share with us there, along with maybe even I'll put the chat in there because sometimes it's good to see what people asked in relation to this conversation at the end as well. So thank you. The dashboard, Epic, Encore, EDW world is fascinating to hear. So we all at TCA definitely appreciate you guys coming here to share your experiences, because we understand dashboards and everybody I think would love to have one. And it's great that you share how you're using it and how it gets built, etc. So before we let you go, we've got a few minutes. We really like to talk about 2025. We would also really like to encourage you to experience Circle a little bit more. And if you are on this call and you don't know what Circle is, reach out to me. But I will tell you, it is our new online community, and it has really been beneficial, I think, to the people who are using it. There's great questions being asked out there, wonderful resources and answers being provided. I just put a couple screenshots on here. This is like the main feed when you open it up. And I wanted to put the member quilt, if you will, up here because we're missing a lot of photos and we'd love to see your face. So if you do have time, please go back in and throw a photograph of yourself up on your profile, because then that helps somebody to find you and then see you on these meetings. And it just helps with, I think, the connection. So if you could do that. But I also wanted to put an example of some of the things that are being shared. Danielle just put a question out there about video games. Alec, I tagged you on that. You might have an answer to any video game groups that are happening in the AYA space. And Kara has put some fabulous flowcharts in recently. So if you haven't been out there in a while, I encourage you to go look at Circle and dig in and make sure that people that you work with get on there too. Share it far and wide. The more we have, we're up to 118 people, I think, the better this community will be. And we are very committed at this time to keeping this going and to keeping it building and connecting and sharing. Then let's quickly talk about 2025. The survey is going to, I'm going to share that QR code at the end. I will also send the link out again. And I swear, it'll only take you 2 minutes. It's really short. We want to hear more about what you want. January, we are going to do a meet and greet, and we haven't quite figured that out, but we do know there's a lot of new people here. And so we just want to have some time together to meet. We actually had a suggestion that perhaps we need to have a longer meeting someday. That maybe we need to take 4 hours and have a workshop, have a roundtable, have more time together, because these meetings evaporate in time. So I thought that was one great suggestion already. But at this meet and greet, we can meet each other, we can talk, we can figure a few more things out. February, we do have Dr. Jake Stein coming in from UNC, who put this abstract at ESCO Quality on their program and actually measuring, because we all like to measure things. And we know that your sites, the people that you answer to want to see that your program is doing well. There is a link to the actual abstract. He's going to come and talk to us about it. Oh shoot, I think I missed an H on there. He's going to talk to us about how they are measuring their program and how that affects the quality of the care that they're providing their AYAs. Rest of 2025 is wide open. So a couple things that have been talked about on Circle is aging out of your AYA program. Do you age your AYAs out, and at what age? Workflows, a lot of talk about workflows, and thanks to Megan at City of Hope, who I believe is still on this call. And I'm going to stop sharing here so I can see your faces. She shared with me Epic's Epic Community Library, where a lot of these processes and workflows can be found. We'll talk about that, I hope, because I want to learn more about those screening tools. What are you using? We've already had a needs assessment screening, I think sometime mid-year, and a lot of you weren't using them, but I keep hearing more and more people talking about using them. A lot of our new sites we are working with are definitely incorporating them in. I think needs assessments are a great way to address the human being that's got the cancer, right? So I think that's worthy of another conversation. There's that epic resource of resources. What is your ideas on what we should be talking about and doing in 2025? This is your collaborative. We want it to work for you. So I'll stop talking.
Can I just say I would love like a 4-hour workshop like on dashboard. And I'm very like starting square one right now. So I'll be documenting like what I've had to do, how I talk to the Epic team and things. So I'll be happy to share whatever I learn. But if we can find like this is the kind of justification you need. This is the kind of conversations you had with your Epic folks. Like all of our Epic systems are a little bit different, but like I'm an advocate for that. So that way we're not reinventing the wheel. And because all of our Epic systems like use the same platform, we can like share with each other builds, flow sheet builds and things. So don't start from scratch. Tell them to use at least or start with a template from another site. Like even if you don't know what that means, they know what it means. Like tell your builders to go into the community, the Epic library and look for these keywords or pull some key things. And Betty, I don't know if you're gonna upload them or if I should upload them, but we can upload some of the templates that we pulled down from that community.
Yeah, Megan has shared with me many, many, many things since, and I just have not had time to take a look at it, but I will share. We'll start a whole new folder on this because I think this Epic Share library is extremely valuable to us.
I'm gonna echo what Megan was saying about the dashboard for ours, or can we have a second chapter on Cerner, which that's what we're using. I know we're a minority, so
Thank you for bringing that up, Shu. And that is one of the questions that we have on this survey that we want you to take. We want to know if you have Epic or Cerner or another program because we would love to accommodate. There are definitely sites with Cerner, so you are not alone, Shu.
For this longer workshop, what do you think would be valuable in terms of structure? Like entirely discussion based, some presentation, some initial discussion about what is it that we want to standardize across dashboards, and then how to implement each of them? Is it valuable to try and bring somebody in from Epic, the company? Is it valuable? Like, what are some of the things that as we look at how we might help facilitate that, we should be thinking about? I threw a lot all at you at the same time.
Sorry, I like went to raise my hand like physically, but I meant to raise it like on the button. I think bringing someone in from Epic would be extremely valuable. I think as all things electronic, we don't leverage it enough, especially as providers, clinicians, administrative individuals. It's just not our training. And so I also have realized, I think maybe Megan, I mentioned it to you in a comment that every Epic analyst or every IT analyst has a different flavor. And so when you're talking to them, some may know what you're talking about, some may need to do some digging. So I've found it helpful to talk to multiple different people. I had one person make my research dashboard and one make the clinical, and they both like collaborated and enhanced each other's points of view. So I think that would be like incredible to speak to someone from Epic because there's so much we don't know.
I think, Alex, I think that the other thing that would be helpful, I mean, we're pretty, Intermountain, we're pretty young in our, we have a collaboration with Huntsman for HIAA, but we're transitioning from Cerner, which was very limited in the information that we could capture and, you know, no dashboard capabilities at all. But we're transitioning to Epic. I would really like to see from a collaboration of this magnitude with all of us involved. I would love to see kind of like, how do you like what are the standard metrics that we should all be tracking, that we should all be in line with, that we should, you know, because what I find is that it's with survivorship, with AYAs, with all of these kind of individual cancer, you know, populations, that it's really independent on each site, which is okay because we all have to have, you know, certain things like that. But to make movement as a whole, like if we could start really capturing the same data and talking about it and really kind of making some, you know, I don't know, building best practices off of that, I think it would be incredibly valuable. And that was in my short time in a, you know, the cancer program for this population. It's been a challenge to capture the data, know what the right data is, and then to benchmark it. It's been very hard. So that's my idea.
So I'm wondering if I'm the only one who I came to this role as an AYA and fertility navigator after 20 some years of being a bedside nurse. I didn't even read my email for like 25 years because I didn't need to. Like somebody told me if I was doing something wrong. So there is so much about the vernacular of how to understand this that I genuinely don't know. And there are so many acronyms that people use, and I'm sitting in these meetings, and I genuinely like I'm lost fairly quickly. Um, so I wonder if there is just a kind soul. I recently had a meeting with our Epic team. It's very, very hard to make progress with your Epic team if you don't go into that meeting having some fundamental understanding of what it is you need and how to ask for it. I had people who tried to help me. I need more help. Is there anyone else that would really just benefit from just like some like just entry level um like tutorial in how to navigate Epic again and how to understand the different tools that you're trying to find, enough for us to be able to approach the people on our Epic team and be able to ask effectively for what it is that we want?
That is a very valid
I would
request.
like that.
Yeah,
I'm
absolutely.
definitely willing to meet with anyone on a regular basis. Like if we want to do every other month or something like that, with a small group, I'm happy to do that. I don't know
Just be the
everything,
coolest
but
person.
little engine who could.
No, you're
Uh,
just the best. Thank you, Kara. That's really kind of
no
you. It really is.
problem. Yeah.
Thinking about
Especially if other people would benefit.
I
Totally.
I agree. I think
thinking
there's
about time, I do think it's really valuable. It sounds like some kind of Epic Cerner, like EMR basics
Yeah.
course, a discussion on what we can measure. And it sounds like Jake Stein's presentation coming up is going to be a great start to that. I know I've had some separate conversations about it too, but really defining some standard metrics that we can measure and then working with an Epic builder. I'm going to use Epic as my shorthand for EMR, an Epic builder, especially from Epic, to help think through how we can actually do some of these um, measures, but also thinking about what kind of implementation and process of care we can automate into the EMR and how we can do some of that. I know that's not exactly dashboard, but it's not dashboard. Sounds like those are kind of the pieces that are most valuable. Is
Yeah,
that
I would
your
say also like we all have to request an enhancement. Like we also all have to request a report, a dashboard or something. So if we could all share how we submitted that request, like what kind of language, verbiage, like and like I used Kara's workflow, like and I modified it a little bit for us and I gave it to the Epic team. Like if we could have like a like very broad bucket, like give this as part of your submission to your Epic team, whoever your Epic builder is, give them this workflow, like with hyperlinks and stuff. If we can get to a point where we have like tools to give to the builders, that also expedites things so much. So if that could be part of those efforts, and because we're all going to be answering the same questions to request these builds, so we might as well be using each other's language and advocating similarly.
it has long been a goal of ours to have a packet that we could just have people print and physically hand and then kind of walk away a little bit.
So
I
you took the language that Kara, like her actual workflow, and you just handed it to the Epic people and they knew what to do with that?
No, that was just to help them visualize and understand. It's just tools to
Because I
help
have
them.
that. Kara's shared a lot of
Yeah.
stuff with me already, but
Yeah.
okay.
So yeah, it's helpful for them to understand like kind of what your workflow is, but it doesn't have the Epic like language, right? Those workflows don't have like the Epic, so that you do need to speak Epic to them to kind
Yeah.
of
Yeah.
You need to talk Epic to them. And from a clinical provider, like when you're like I started off with giving them slides. They didn't get the bigger picture until they saw the workflow and was like, oh, this is how it's going to be applied. Oh, do you want this and that? It really just gives them like a starting point.
Okay.
I put those workflows recently. Rachel, I don't know if I sent you those.
You
I
sent
will.
me your whole like slide deck from the last time that you spoke.
Oh, I've done a lot since then. Let
Oh,
me.
great.
I
Send me
think
all the
that
things.
I think that 101, Rachel, is kind of a good idea.
Yeah.
So where
And
and when
yeah,
is that?
yeah, and then the specifics, Megan, like what is it? What could I give them? I mean, we've seen that help speed things up. So that's really what we want to do. So I don't know if that's 2 meetings or the part of this 1 4-hour meeting, or do we do a 101 kind of first to get everybody sort of on the same page? So then we can move to a more detailed conversation. We can talk about that. You can put it in your survey if you haven't done your survey yet. Also, and anything else that you want to talk about as well. Anything else?
I could talk forever.
Yeah, you guys are
Probably a good thing that you count me off. Count me
yeah.
on.
They
Well,
might be talking.
please put more questions up in Circle and ask them. Kara is a very active member of Circle, and we love and appreciate that. And so are so many of you. So, but there's great stuff up there to look at, and we can answer some of these questions in the short term before we're able to put together this longer meeting, which we will definitely work on for the beginning of the year. So thank you so much. Have a great holiday season, and we will see you all in 2025.
Merry Christmas.
Merry Christmas. Yes.
Hillary, I'm so
Yes.
sorry. Before I let you go, or
Oh,
Alec,
yeah.
I heard Alec mention but I don't know how to access that. Where do I find that? Where is that meeting or that how-to that he was referring to?
These are just things that I was trying to understand make sure I understood what the group wanted. We haven't planned anything yet.
Oh,
We're
okay.
gonna,
I'm sorry.
that's,
I thought you were referring to an actual like seminar or webinar that existed already out in the world. Oh,
Not
bummer.
yet.
Okay.
that's what we're trying to get at. So
Okay.
this
Sorry.
will be a really good exercise for everybody because we'll
Yeah.
see it's helpful, and we know different people are at different places. So you're not alone out
Yeah.
there not really understanding all of this language and what's step one, what's step two, what's step three,
Honestly,
like
not
from
my gift.
yeah,
Like,
yeah,
let me
no,
start your IV. I can do that.
yeah,
But this is
right.
frustrating. So I appreciate that. I think I hijacked the end of the meeting just a little bit, but
No, not at
No.
all. Not at all.
Oh,
Really
that was a
valuable.
perfect request because you are not alone. And
okay.
I
And,
love
and
the whole
yeah,
Epic Speak. If you don't go to
Yeah.
digit heads with Epic Speak, because they don't
Yeah.
know clinical, it doesn't
No.
mix.
no,
No,
yeah.
I had a meeting with them to try and get them to help me with this stuff. And I had Kara's whole slide deck. Like I had things that Gina sent me from St. Louis. I mean, I had asked people for their resources so that I could come in prepared. And the meeting was 5 minutes long, and they were like, "Yeah, it doesn't seem like it's really clear what you want me to do." So,
I'm sorry.
Yeah.
it's
Yeah.
okay. It's
We'll, we'll,
okay.
we'll get you
I
there.
yeah.
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 I really desperately want to be able to do this, but I'm
Nice.
old. It just takes me longer to figure this stuff out than it
You're
does.
not.
Like, I feel like the young people just sort of are born with this, or somebody downloads it directly into their brain when they're born, and I don't have that. So,
You missed the epic download.
right? Like, I know fruit stripe gum and all kinds of other crap that they
It's
don't know, but like I don't know how what this stuff works. So I need to learn it. It's like an entirely new language that I need to
yeah,
learn, and I'm working on it, but
yeah,
We'll get there.
All of
yeah.
us,
yeah.
all of us are learning it.
Yeah,
Yeah.
it's good. I'm
And I
glad I'm
think
not the only one.
I was at the hospital when they switched from paper charge to Epic,
Yeah, I do
which
too.
is probably what you
Yeah,
did too. And
yeah,
there was very little teaching of Epic, and especially in how to
yep.
manipulate it or change it or build add on to it. It was more like this is where you're gonna type your chart notes, and here's we weren't really part of the builds, or at least we
Mm-mm.
of these things that we see on Epic. So I think um you're in a place where many people are. Well, we didn't really, I don't know how it got there. It was just there when I signed on, and there was
Yeah,
my
I find new things all the time that I
yeah, but I
didn't know
didn't.
existed. Yeah,
Right. It's like your Mac or your computer. It can probably
it's exactly like
do
that.
a lot more than you think it does,
Yeah,
but I don't know how to do any of that. So
yeah. I mean, I
And
had to have somebody help me download my my license every time I got it renewed because I didn't know how to do that.
It's okay. Alec
So
has to put my signature on things, so don't worry about it.
And Rachel, remember, Epic was designed for billing, not patient care. So
yeah,
it's
there's a
it's
lot of things I
interesting.
think were designed for billing and not patient care.
Yeah.
Yeah.
So
So
we're gonna
thank
get there.
you.
We're gonna get you there. But yeah, you have
Oh,
great good.
thanks. That's
I really
kind.
think Megan, Bryn,
Yeah.
Kira, they're incredibly knowledgeable and lovely. And I know if you reached out to them, they would be so happy to help you.
Yeah.
And
Kara
Michelle
has been
too.
helping me. She's
Yeah.
incredibly generous with her time,
Yeah.
and I'm really grateful for it.
Yeah. And and
So
ask a couple people so you get different, then you'll pick up those words and you're like, oh yeah,
that's
this
my
is how I
hope.
say it. Yeah.
Every time we have one of these meetings, I write down like 3 new acronyms that I have no idea what they mean, and I have to look them up. I'm
If
glad I
you
wasn't the only one who didn't know that first one.
No.
EDW,
Yeah.
yeah,
Nobody knows all the acronyms, and some
Yeah.
hospitals use different acronyms for the same
absolutely.
thing. Some
That is very, very
hospitals
true.
within the same health system use different acronyms for the same
Yeah,
thing.
they really do.
So acronyms are always
Yeah.
needed because
Yeah,
names are
they're like
long.
25% evil,
Yeah.
acronyms.
Yeah.
Do you
They're
keep them?
useful, but yeah.
Right. They're
Do
great
you
for
write? Do you
short
write
notes.
them all in the same place? Because that might be a nice little list for us to put on Circle.
It's not the worst idea in the world. I have a cheat book that has a lot of this information in it that I've been slowly kind of gathering over the last year. Yeah, a lot of acronyms, a lot of what does that hormone mean?
Mm.
It's just a lot of, yeah. I don't know if
Yeah.
it'll make sense to anyone except for me, if I'm being honest, but
Yeah.
yep.
No,
Yeah.
I can tell some of the new hires that get brought into programs when I talk
Yeah.
with them and I'll say something and they hesitate and I'm like, because I don't hear me speak in acronyms or in special
Yeah.
words anymore. I'm talking,
Yeah.
what's that called, jargon? I don't realize it. So
Yeah, I mean, none of us do, right? I mean, that's one of the textbook characteristics of medical people is we don't hear the way we're saying things or phrasing things for
Mhm.
people. And it's a difficult position to be in because you don't want to dumb things down, especially not for AYA patients because they're so on to you so fast. I mean, I remember when I first started, I had somebody who was like, "Why are you talking to me like I'm 5?" I was like, "Oh, you know what? You're right. I'm super sorry. I'll stop." And they're not wrong, but also they won't ask us to like they will just kind of go past it and not understand what we've said
There were a
instead of
lot of
asking.
presentations about this at
Yeah.
AYA Global Congress. There was a really fascinating one that showed that a patient forgets what 40% of what you say
Uh-huh.
immediately.
Yeah.
And of the stuff they remember, 50% of it is incorrect.
Yeah. I believe that.
Well,
Not
that's a
to
little
mention they just don't
discouraging.
know the words, right? Like,
Yeah.
we do have to jump to another meeting,
Oh, I'm
but
so sorry.
No,
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 Have a
this
really
is
good
really
day.
helpful, and maybe we can find another time to schedule to actually like spend more time on some of this.
Oh, that would be great. I would really appreciate that.
we'll
Thank you
reach
for
out,
your help, you
Rachel.
guys.
Thank you so much.
welcome.
Take
Take care.
care.